Thank you for joining us. My name is Theron Steinke, and I am honored to introduce you to our team of clinical educators and local prosthetists and orthotists. It is our firm belief that patients living with limb loss receive the best outcome possible when we take the team approach to their care. The relationship between the prosthetist, therapist, physician, and other treating medical professionals starts and ends with open communication and education. We learn just as much from you as we hope that you learn from us, and it is our goal to make these presentations a conversation, not a lecture. We sincerely thank you for your support and devotion to this specialized patient population.
Hi, my name is Brooke Osteen, and I'm an occupational therapist. I work for an orthotics and prosthetics company in the Midwest, presenting education to both practicing therapist students as well as consulting with our practitioners for patients with both lower and upper extremity amputations. I have worked in a variety of facets in the industry, working for 2 years in acute care in hands, 6 years as the lead OT in the burn center, 1 year in medical sales, selling dynamic splints, and most recently, 8 years for SRT prosthetics and orthotics as the OT on the upper extremity team. My passion is helping as many people with amputations as possible through the training of therapists in all treatment settings. I want those therapists who may only see a few amputees a year to be just as comfortable as those therapists who see many amputees each year. I also want to encourage interdisciplinary care with our PTs and our PTAs so that we can achieve the best functional outcomes for our amputee patients. Hey there, in this presentation, we're going to talk about preparing your patient for the prosthetic process. So when does this all start, right? It starts on day one, or even better, maybe it starts immediately at the time of amputation. So as medical professionals, we all need to be working together as an interdisciplinary team to really consider what were the previous functional tasks of a patient to prepare that residual limb prior to, at, and after amputation so that we can set this patient up for success for a prosthetic device, right? So what did I just explain? The best case scenario, right? Does that always happen? No, it sure doesn't. I get it, right? But as an occupational therapist, what I want you to do is I want to train your brain to start thinking about this prosthetic process a lot sooner than maybe we have in the past, all right? So I do want you to start thinking about it day one. I want you to start thinking about it as soon as that referral comes through on your printer, hot off the press, that there's an amputee in your facility, in your hospital, wherever it may be. I want you to start thinking about what we need to be doing and what's next so that we can best prepare this patient for good functional outcomes in regards to a prosthesis, okay? So it all starts very early on, and it all starts with positioning and range of motion. Now, I want you to also think about the leading cause of upper extremity amputation, right? And that's due to a trauma. So the information I'm giving you, use it as a general guide, right? So we do need to refer back to our physician to clear some of these tasks to make sure our patient is okay to continue with this process, or sometimes we need to use our best judgment. If we have an unstable fracture, if we've got new skin grafts, if we've got a free flap, right? We've got some of these things. Use your standard time frames and timetables to begin some of these activities. So first thing I want you to think about is gentle range of motion. And as long as a physician clears, gentle range of motion can begin on day 2. What I have found is the more we can actively get a patient involved in some of these activities, kind of the better they're going to do from a biopsychosocial piece. So if they've got something that they're actively participating in, then it kind of deters them from allowing to pull the sheets up over that residual limb and have neglect like this amputation isn't even there, all right? Now, in regards to phantom limb pain, isometrics and isotonics can begin day 5 and day 7. So again, it's that active participation on the patient's behalf to engage in their care. So we're not just going to forget that that residual limb is under the covers. Rather, we're going to engage in it. And we're going to get those muscles working, and we're going to give those nerves a job, which ultimately is the goal of reducing that phantom limb pain. In regards to frequency and duration, 10 to 20 reps every other hour. Okay. What I like to do is actually issue this as a home exercise program or a home hospital room program, right? So wherever your setting is, these are exercises or activities that can easily be printed out, left on the bedside table, and ask the patient to complete on their own. Again, so they can have that motivation and active participation in their care. Inevitably, phantom limb pain comes next. So what are some of the ways that we can manage that? Well, that's the general purpose of those isometrics and isotonic activities, okay? A couple of the other things that I like to do are even integrating isometric exercises as well. And there's another thing called mirror box therapy. Again, so no different, right, than something that you would use in somebody that's had a stroke and you're working on some neuro-rehab activities with. Right? Now, a couple of tips and tricks. You have to consider the biopsychosocial piece in an upper limb amputee and doing mirror therapy. So the first time you set that box on a table, specifically we'll talk about a transradial amputee, you put the residual limb inside the box and they look into the mirror and they see two hands, you may see waterworks, right? More times often than not, that's the first thing I see on that first rep of mirror box therapy. And you know what? That's okay. I pull up my chair, grab a box of tissues, give them a couple of pats on the back, and say, it's going to be okay. And their mirror box therapy for the day is just merely being able to look in the mirror and see two hands again. Okay? And some people will ask me, do you use this technique in the same way as you do guided motor imagery? And I don't, right? I like to refer to this as the Brooke method, right? No research behind it, just lots of repetition. So here's why I don't do it like guided motor imagery, right? The central nervous system post-amputation is kind of cattywampus, right? It's just trying to figure out what the heck happened over there, right? Those nerves are still active. And if you ask the patient, can they still feel their hand or still feel like their hand's in a certain position? They can almost in 2 gigawatts tell you just exactly how that hand feels like it's stuck, okay? So what I like to do actually is take this sound hand and position it in the same hand that what used to be their other hand is positioned in, right? So when the central nervous system sees that in the mirror and they're seeing two hands, it's like, oh, that registers. I know what that feels like because that's how that hand is. And they will progressively, as they're able, work out of the position that they feel like they're stuck in. So I have found not only does that work to help phantom limb pain, it addresses the biopsychosocial piece, and it's really a good way to get them out of that pattern that they're stuck in, which then would help in the case that the patient's going into a myoelectric prosthesis and calm down those nerves that are hypersensitive to be able to activate those nerves that are functional to operate a prosthetic device. Here you'll see a patient demonstrating a mirror box therapy. I always say if we can get them doing 3-5 times a day, 5 minutes, then that's sufficient as far as mirror box therapy. Okay. So what's the next thing we need to start thinking about? Well, it's that range of motion that maybe we've lost. So again, leading cause of injury, trauma. So the likelihood that there is injury to another joint on that limb is pretty big. So we need to be looking at the person as a whole. So not only range of motion on the side of the limb that was amputated, but on the contralateral or sound side as well, right? And these patients can get very involved and very overwhelming first. So I always want to say, don't forget your grassroots and where you came from and how important active range of motion is to a functional task. So I always like to teach and tell stories at my failures, just so it seems like I'm a real person too. And at one point, I screwed this up, okay? So, and if you do, it's okay, right? Well, we all learn big, valuable lessons. So I'll never forget, I had a patient going to a specialist for a very specialized surgical procedure at the time called targeted muscle reinnervation. And I'll never forget the day. I had my pager on, front desk paged me, and they said, "Hey, Brooke, Dr. Kuiken's on the phone for you." And I'm like, that can't be so. The real Dr. Kuiken, the inventor of targeted muscle reinnervation, wants to talk to me? Then I remembered I had a patient there for an assessment that day for the surgical procedure. So I got on the phone and I was like, "Hey, Dr. Kuiken, how is everything?" And he's like, "Well, I got to tell you, this is a first." And I'm thinking, oh, this is a first, like a therapist not at Rehab Institute Chicago or Shirley Ryan Institute having a patient with TMR. He's like, "No, this is the first time I've rejected a patient for the surgical procedure based on their contralateral side doesn't have enough range of motion." Talk about gut check. Whoops. So that's why I always say, don't ever forget about range of motion and kind of where you came from and how important that is to functional tasks. My tip or trick here is I always liked to paper clip a sheet of paper to the inside of the chart. And I know, right, we're not using as much paper charts as we are using EMR anymore. I get it, right? So maybe you've just got a cheat sheet somewhere on your desk that you're keeping track of this. And every session takes some sort of measurement, right? So not only are you keeping track and you're cognizant and aware of where their general range of motion is, but when you have to do your progress note or discharge summary, you've done all the heavy lift and hard work, right? All of those measurements are right there at your disposal, and it's easy to fill out that report and keep moving on. Next comes strengthening and conditioning, okay? By strengthening and conditioning, this doesn't have to be rocket science. It doesn't have to be anything crazy and silly, right? My tip or trick here is find a scap stabe program and a rotator cuff strengthening program that you like, that is easy for the patient to replicate with good posture body mechanics. Keep it in your back pocket and pull it out all of the time when you're seeing your amputee patients, right? Nothing that's over the top. It doesn't have to be crazy. I used to always just give for scap stabes, give my patient horizontal ab and adduction, diagonals, and external rotation, and I called that good, all right? For rotator cuff, I do really like a prone program because they have less ways of cheating, or if they are cheating, you can tell on a mat table really easily, okay? So kind of some tips and tricks there. My story of failure here, super funny, right? So I had an amputee patient come to me and say, "Miss Brooke, have you ever looked back at my home exercise program?" I'm like, "Yeah, it's super comprehensive. You're going to be ready to rock and roll when your prosthetic device is ready." And he's like, No. Have you ever looked to see how often and how much, right, my frequency and duration that you wanted me to do these exercises? So I was like, "Well, no, I haven't really counted them all. Why?" And he's like, "If I woke up and I started my home exercise program and I did the amount of reps for the amount of holds, for the amount of times that you wanted me to do throughout the day," he's like, "I would be doing my home exercise program from the time I woke up until the time I go to bed, and I still wouldn't be compliant with your recommended program." I was like, whoops. So here again, another tip and trick. Don't forget, as the patients progress, you can take things away, right? Put an X through it. You don't have to do that anymore. You graduated. So not only is it keeping their home exercise program in check, but it's making them feel like they're making progress towards their ultimate goal of a prosthesis. Another thing we need to be working on, myocytes, right? So what does that fancy word mean, right? A myocyte is just really a motor point where we're going to pick up that EMG signal and the surface electrodes for a myoelectric prosthesis. That's where it's going to read the EMG signal so that it can operate the prosthesis, all right? Here's a scenario where you may ask your local practitioner, "Hey, do you have anything you can loan to me that I can borrow so that I can look and watch and give some biofeedback and cueing to my patient during this process?" Because it does make it a lot easier, okay? As you're developing those myocytes, they do need to have 3 characteristics that we're going to talk about, okay? The first is strength, meaning microvolts. So that's how in the industry this is measured. And it goes from 0 to 100. Insurance says they need 5. You'll understand in just 1 second when I give you the third characteristic of a myocyte why that seems silly. I like them as far as strength to be somewhere between 30 and 50 on a consistent basis, okay? The next is endurance. So they need to replicate that 30 to 50 microvolts of signal over reps of 10 and sets of 10. And why is that important? Well, think about, in the grand scheme of things, how big that wrist extensor muscle or that wrist flexor muscle, which is what you're going to use in a transradial patient, how big are they really? And say a patient wears for 14 hours out of the day. One time we put a counter on one of our patients, meaning we counted how many times he opened and closed. In a 3-month period, he opened 1 million times. So that goes to show you why functional endurance is so important, all right? And last but not least, we need separation, meaning we need to see an EMG signal from our wrist extensor and our wrist extensor only when the patient pulls their wrist back, and from the wrist flexor and wrist flexor only when they push their wrist in, right? While prosthetics are amazing devices, sometimes they get a little bit confused when they get too much information. So they can't decipher on what they're supposed to do. They're not really good problem solvers. So we need to make sure that they have the signal that was intended to move the joint when they need it. And that's why I say that 5 microvolts is pretty silly. It's going to be pretty hard to separate 5 microvolts when you think about the relationship of that agonist-antagonist relationship of your wrist flexors and extensors. And that's why I like that strength number to be closer to 30 to 50 because it's much easier separated. Here's a video that you're going to see that microvolt testing that I'm talking about. So in the back, you'll see that Myo Lab 2. So we are using those surface electrodes, and then that tachometer is showing real life EMG signals, and that's how we assess that strength, endurance, and separation that would make a patient ready to advance to a myoelectric prosthesis. Next, don't forget about ADL retraining, right? So I think one of the most important things to think about is that while prosthetic devices are super cool, right? Cooler than cool, they are man-made devices. So we are going to have some mechanical failure. So to me, there's nothing worse than a patient only learning how to do an ADL task with their prosthesis, because then what happens when we have some sort of device failure and they don't have that device present to complete that ADL task? Now either they just aren't doing it or they're having to ask for help. To me, dependency is kind of like a swear word, right? So I like to teach them how to do the task not only with their prosthetic device, but what is a safe, modified way for them to also do most of, if not all of their ADL tasks using their residual limbs or their residual limb and their sound hand. Believe it or not, at the transradial level, even as a bilateral, there are very few modifications or adaptive equipment that a patient would need to be modified independence with their ADLs without or with a prosthetic device. As we start to talk about that transhumeral level, whether it be unilateral or bilateral, that is when we have to start adapting the environment quite a bit more, or making some big time changes to their environment so that they can do things with their residual limbs without a prosthetic device or adaptive equipment. Okay. The other thing I think it's important to think about, like we just talked about, is those bilateral high-level amputees, right? We need to teach them footwork. And when I say we, I don't necessarily mean an OT. Ready? Mind blown? This is where it would be super appropriate to get a PT consult, right? So we've talked about a lot of things up until this point. And like I said, these patients, they can get very overwhelming very quickly. And you find yourself down this rabbit hole where you maybe completely forgot strengthening, maybe you forgot about range of motion, maybe you're so focused on ADLs that those things don't matter, or maybe you have a really stuck, stiff joint and you're so focused on range of motion that we're not looking at one-handed ADLs, right? You've got a lot on your plate and it's okay to share. So footwork is one way where I will tell you that it's an okay situation to ask the PT for help. So as that high level unilateral or high level bilateral, truly they should be using their feet kind of like they're using or would have used their hands. So getting that big toe and that second toe with increased coordination and dexterity. So your patients can complete tasks at floor level as a method if their prosthesis is broken, to have some functional independence. Or maybe they decide, you know what, hey, first thing in the morning or on the weekends, I just don't want to wear, and I want another method for getting these tasks done, right? Success is a relative term as it comes to these upper limb patients, and we need to give them more options than just a prosthesis, right? So, you know what? We've talked about all of these things, and you know what we haven't even talked about yet? We haven't even talked about them getting a prosthesis. So those are all of the things that you should be focusing on prior to the patient getting a prosthesis, or those are all of those things that make pre-prosthetic therapy and an occupational therapist so very important in an upper limb patient's life, right? So now let's talk about it. Now we need to get them a prosthesis, right? So the first thing I would recommend, and my first tip or trick, is when it comes to training these patients, reliability and consistency of these devices is so incredibly important, right? They need to know that this thing is going to do what they want it to do on the first try, okay? So think about this. Think about that biopsychosocial piece. Think about a patient, an upper limb patient, getting enough gumption, right, to wear their prosthesis out to eat with their family for the first time. The last thing they want is to put a fork in their hand and try and feed themselves and have their fork go flying across the restaurant, right? They already feel like they stick out, like I would say, kind of like a glowworm, right? That whether it's true or not, everybody is just staring at them. So that's why that reliability and consistency is so important. They need to have confidence. So what you're going to be doing throughout that training process is you're going to be providing them with a lot of commands and a lot of verbal cues to kind of check that reliability and consistency. So the first thing, my first tip or trick, is develop a language, right? And what do I mean by that? So again, guess what I have? I have a story of my failure, right? So 2 patients about the same time that came across my caseload, both transhumeral patients, one absolutely killing it. The other one was really kind of struggling to catch on. And so one day I just had an open, transparent conversation with that patient. And I said, you know, hey, let's talk. Before we start with training today, let's talk. Like, what's going on? What's the problem? And you know what he said to me? He said, Brooke, I have no idea what you're asking me to do. And I was like, huh? What? Talk about feeling about this big as seeing a patient as a whole person and having client-centered goals. I totally messed it up, right? And so here's what we did, and it was probably one of the most favorite things that I've done, is that we took a video of his prosthetic device moving. And this is one of the first things that I would suggest. So shortly after evaluation, maybe your first treatment session, right, is just take a video, if you can, on the patient's phone of the prosthetic device moving. So the hand opening and closing if it's a myoelectric device, or in a body powered device, it's still going to open and close. If there's forearm rotation, if there's wrist flexion and extension, if there's elbow flexion and extension, whatever moves, whether it's externally powered, meaning there's a motor that powers it, or it's mechanical, meaning it's done by body powered, take a video of that moving, okay? Have the patient watch it and have them give you their terminology for what that makes the most sense to them, right? So y'all, I'll never forget it. As I was entering this industry, I had an OT say to me one time, well, you have to talk like a prosthetist, right? Because that's who you're going to interact with is with a prosthetist. And did I interact with a prosthetist? Yeah, I sure did. But the amount of time I interacted with a prosthetist in comparison to when I interacted with the patient population was really small. And so after that patient and that situation, I kind of stopped myself and said, why am I talking like a prosthetist? I'm not a prosthetist. I'm an OT. I'm going to talk like an OT. And ever since I kind of changed that mind frame, it's worked really well. So like I said, just develop that language. And then if if the communication is struggling with the prosthetist, guess what? Then you have that video to show them and say, hey, this is what we call it, so that you're all on the same page and that modifications and adjustments and all of those things can be done with everybody understanding just exactly what's going on or what words mean things. The next thing is pre-positioning, right? So one of the big things I think that's different in upper limb than it is in lower limb is not the quantity of movement, right? So as therapists, you're going to be able to get this patient to operate their device, no problem, right? But one of the things we need to pay special attention to is the quality of movement. So yeah, we know they can do it, but have we taken into account body mechanics and joint protection principles? So we're saving not only the rest of that residual limb, but the contralateral side from any sort of repetitive injury, or are we reducing that risk, right? And one of the best ways to do that is what I call pre-positioning or setting the patient up for success with their terminal device, okay? What am I even saying, right? Well, here we go, right? So what I like to do for a patient is I like to set up a task across the room. So maybe it's just a water bottle on a table initially. And I say to the patient, okay, with their arm at their side, so let's think about it from a transradial perspective. With your arm at your side and at your starting position, what are the motions that you would need to do to grasp that water bottle and bring it to your mouth? Well, probably my shoulder can stay in the same position, okay? Maybe slight humeral flexion. Well, then I say, okay, well, what would you need to do with your elbow? Okay, well, I'd probably need to flex it a little bit, okay? So that's the first thing. Let's get that flexed to the right position. Well, let's say their hand is pronated. Well, probably gonna need to move that to neutral. So whether they reach over and mechanically move it from a pronated to a neutral position, or they use their wrist rotator to move it from a pronated to a neutral position. And last but not least, they probably need to open their hand. So you saw a sequence of movements in joints, right, as we moved distally. So the last thing we want to see is a patient be unprepared for a task, right? So they walk across the room, they get to the water bottle, and they're leaned forward, and they're not reaching forward, and they've got trunk flexion, and they've got all these cattywampus positions so that they can grab the water bottle. That leads to those compensatory strategies and repetitive injuries, right? So by pre-positioning or talking them through essentially the motor planning, that's really what you're teaching them. By talking them through the motor planning of the task, you decrease those compensatory strategies, right? So initially we talk about it from the other side of the room, and then each time they cross the room to the task, we add a single joint at a time. So the first time across, they're just going to make sure they get their elbow in position. The second time, they're going to work on their elbow and then their forearm rotation. And then the third time, elbow, forearm rotation, hand position, right? So as they get to that task, they're ready to go, right? Setting them up for success. They're ready to go with their arm in that pre-positioned position to grasp the water bottle, bring it to their mouth, and take a sip, okay? So you would go through all of the joints that move on a prosthetic device to make sure that the patient can accurately pre-position those for all potential functional tasks. So here's a challenge, right? This is pre-positioning at its best, probably one of the best videos that I've ever seen. So I want you to watch Brad, who's a bilateral upper limb patient. So he's a left wrist disarticulation and a right transradial, as he does some simulated tasks in the kitchen and getting something out of the microwave and putting something in the oven. You all, this is pre-positioning at his best. Watch him. See how many times, if you can count, that he changes the position of his left hand so that he can complete this task without any sort of hiccup. Okay, here we go. So I think what's so powerful is just the fluid motion in which he can do this task. I'll quit talking so you can go. How cool was that, right? So about 12 or 13 times, right? So were you correct? That's how many times he changed the position of his left hand in order to complete that task fluidly with good body mechanics and joint protection principles, right? There are a couple of different ways that you can go about pre-positioning. That would be something that would be great to reach out to your local team to say, what's your best recommendation for this, okay? Now we're going to talk about control training. So remember how I talked about it's so important to build reliability and consistency in these prosthetic devices. This is where it comes from, right? So I'm always one to tell my therapist how you do things pre-prosthetically and in the order in which you do them pre-prosthetically. It doesn't really matter to me as long as we get to the end result of a patient being modified independent with their ADLs and a residual limb that's ready for a prosthesis, whether it's a myoelectric device or a body-powered device. Now, when it comes to control training, you see the happy-go-lucky person in me shift a little bit, right? It's like a light switches, and I am incredibly particular about how this is done. Again, this would be something good to ask your local team just exactly what their preference is. I am going to teach you via what we call the Autobach method, or it's a manufacturer's way of teaching this. It's kind of an industry standard. There are some deviations to this, but just know that that's the method that I will teach now. So how do they build reliability and consistency? It is through that quick control training and lots and lots and lots of repetitions. We're talking reps of 10, sets of 10, massive sets of 10, right? And we're always going to watch to see how reliable and how consistent are they. So the important thing to track here is, did they do what you asked them to do on the first try? If they didn't, and it takes multiple attempts, it didn't count. Doesn't mean you restart your set of 10. It just means that goes into your percentage of how accurate a patient is. And you're going to want to see them about 90 to 95% accurate before you move on to the next step, okay? So here goes. So the first step is they should be able to operate that joint or component on the first try, right? So what does that mean? That means you're going to say, as a transradial, Mr. Jones, open your hand. Does he open his hand on the first try? Mr. Jones, close your hand. Does he close your hand? Maybe he's got an elbow. Mr. Jones, bend your elbow. Does the elbow bend? You don't care how far the elbow bends at this point. You just care that on the first attempt that he was able to bend the elbow. Or you say, Mr. Jones, extend your elbow, right? So we're just given single motion commands. And can they initiate that joint on the first attempt? If they did, a success. If they didn't, failure, okay? The second step is that once they're able to produce the motion upon command on the first trial, now you're going to go to a desired location, okay? So that's the second step. That first step, it's going to go pretty quick, right? Usually they'll get that in the first couple of treatment sessions. It's the second step, right, where you might find yourself stuck for weeks, sometimes if not months, depending on the complexity of the device, okay? So what does this step look like? This step might sound, Mr. Jones, can you open your hand 50% of the way? Mr. Jones, can you flex your elbow to 45 degrees? Okay, now flex to 90 degrees. Extend to 45 degrees. So you're going to give them a joint that you want them to move to a desired location, right? This can get a little tricky. So one of my favorite things I like to do here is actually have them mirror my motion. And you'll see that in a video in just a moment. But I think that biofeedback of seeing somebody else or matching what you're doing with somebody else is so incredibly powerful, and that helps them increase their speed of being able to get that 90 to 95% accuracy, okay? The last step in control training is introducing a speed, right? So you want them to move the joint on the first time to a desired location with a desired speed. So why speed? Why speed? Why is that important? Well, what you're doing here is you're developing proportional control of the device, right? So that if they go to reach a styrofoam cup that's full of coffee, that they're not powering that grasp every time and crushing through the cup and coffee's going everywhere, right? They already feel like there's enough attention drawn to them anyway. They don't need to be spilling coffee or flinging their fork anywhere, okay? So the speed component allows them to develop proportional control. Or as I tell them, it develops the finesse of the device so that they can slowly close around a cup with the fluid in it without crushing the cup and bring it to their mouth to take a drink. So a command for that might sound something like, Mr. Jones, open your hand half of the way slow. Mr. Jones, close your hand half the way fast, right? So that you're giving them a speed to the location of the joint that you're moving. So here's a couple of videos that are hopefully going to help it make a little bit more sense. So in this video, you're going to hear us say, or the command to the patient is going to be bend your elbow to 90 degrees, right? So you see the first time he misses it. Second time, nails it 90 degrees, okay? We were actually asking him, bend your elbow to 90 degrees and open your hand at the same time. So we were working on a little bit of simultaneous control here as well. But you can see in that first rep, I wouldn't count that as he passed that 90-degree mark. The second rep, nailed it. I would count that. That would be a positive, right? The next video I want to show you is absolutely hugely powerful. So what you see here in this video is you see a bilateral patient. So he's a transradial on one side and a shoulder disarticulation on the other side. Two completely different control methods, right? So tons of cognitive focusing here and recall. But this is where I was talking about that mirror effect, right? So you see her producing the motion, him looking at her and then replicating that. So that's where you see that power and how appropriate that biofeedback is and how that contributes to the success of the patient with control training. So what comes next is putting it all together, right, in repetitive drill training. And some are going to say, well, wait, hold on. Like, they haven't done a functional task and they haven't grasped anything yet. I know. And we don't want them to, okay? A functional stimulus, as we would call it, can kind of derail this, if you will. So again, we're trying to build that reliability and consistency prior to applying it to a functional task. So you want to create that neuroread plasticity or pathway before you apply it to an ADL task, which is going to be way more challenging for the patient than these repetitive tasks that we're asking them to do, okay? So post-control training, now we're talking about repetitive drill training. So what is repetitive drill training? Essentially, we're kind of putting it all together. What does that mean? We're putting those first 3 steps that we did with control training all together in kind of a functional task, right? So back to my bilateral patient. What you're going to see him do in the video is you're going to see him move blocks up and down a Velcro strip on a door frame, right? So now I'm asking him to be consistent that he's moving his device the way I want him to on the first try, right? He's taking it to a designated location on the strip via my verbal commands, and he has to watch his speed, because if he can't control his speed, he's going to overshoot or undershoot where I asked him to place that block on the Velcro strip. So that's what I mean by putting it all together, right? My true favorite way of doing this is that blue clothespin graded pincher box, right? I don't know the specific name for it. That's just what I call it. It comes with the red, yellow, green, and blue graded clothespins, and it has the vertical bars, and if you're lucky, nobody's lost the shoulder flexion pull, right? That's my favorite. And why? Because they have to grasp the clothespin, so can they move the device? They have to pre-position and control, so they'd have to change the orientation of their terminal device, and then they have to put it in a vertical plane on the shoulder flexion pull, right? So it gets all of those pieces and parts in one task. Why did we change to the door frame? He'd done that graded clothespin box so many times that one time he came into therapy and he looked at me and he said, Miss Brooke, If you ask me to do that graded closed pinch box one more time, he's like, I'm not staying today, right? Got it. Point taken. Time to change up the task. And that we did. I will give you caution to the wind. If you have a material maintenance department that's super stickler and you put tape or Velcro sticky back on a door frame, it's going to take the paint off. So just so you know, they may not be very happy with you when you take that Velcro strip off. You're welcome. I saved you a little bit of a tongue lashing today, okay? So again, we've talked about not incorporating a functional task at all and how important that is. Well, once they master that repetitive drill training and they've gotten to that 90 to 95% accuracy, that's what we call mastery, or that's where you start to incorporate those functional tasks. And why? Because you've gotten all the kinks out, right? All those first gen problems that's what you worked out in doing your control training and repetitive drill training. You've created that plastic response in the brain, right? That CNS system knows exactly what it's supposed to do, how far it's supposed to go, and with how much speed. And that's where you get to bring in the functional tasks, and they get the mastery and they get the success of functional independence. And this is what it looks like when it becomes a beautiful thing. So a little bit of control issues there and letting go. Gonna use this chin to open up the top. And remember how we talked about how it's okay to incorporate a PT into these high-level bilaterals or even a transradial bilateral? Here's why. How cool is that, right? To have the core strength and coordination and dexterity to do that, to open the lid to the washing machine. He did use his feet also to push the buttons. And that's where doing why it's important that the prosthesis does what it's supposed to on the first try. Imagine if he went the wrong direction and the laundry soap spilled out as he went completely around the opposite direction. So hopefully that ties it all in for you, and that you see why it's so important that these steps are produced in the way that they are. And more importantly, I hope you see that this doesn't have to be intimidating, and that really, truly, as an occupational therapist, these are all things that are in your wheelhouse and all things that you're perfectly capable of teaching a patient. I'm going to now turn it over to your local team for any questions. Thank you so much for your time. Much appreciated. Have a great day.